So in preparation for the talk, I came across so many things that I was not aware of, or which are being done across the world. It almost felt like reading through a science fiction novel as to what we are going to probably have in the next decade or so. So the question always for an innovation or for any change in the thought process begins with why. Why are we trying to do this, or why do this particular thing? So we know that we are using cement in our knee replacements, but there have been certain issues with sort of bone and cement interface, which leads to certain problems and which have prompted the question of what if we do away with the cement. So cementless knee replacements have been around for a while, though I haven't used them, but the literature is replete with reports of cementless implants being used, particularly in the young patients. And they have got a checkered past. So some of them have not done very well. Some of them are doing reasonably well. So we'll see what is the current thought process amongst our fraternity's attitude towards towards a cementless knee replacement. So what has happened in the past few decades is that there is an improvement in the component fixation due to direct osseointegration. Our knowledge of hydroxyapatites, of sintered beads, of sort of plasma spray porous coats have improved. Metallurgy has improved. Our surgical efficiency has slightly improved. We are moving towards preservation of the bone stock, and we would all like to reduce our complication because of the cement impaction or wear debris. So in principle, these cementless components all have osteoconductive component surfaces. We have learned from the failures from our the RSA studies or the biomechanical studies which were pertaining to the cementless implant in the early cementless design. And these sort of failures have been subverted or changes have been incorporated in the modern designs, which have sort of developed a resurgence in the interest of our community towards the cementless implant. So currently, the main indication of a cementless total knee arthroplasty is a patient who has a good bone quality and which has got a potential for a good osseointegration. So that if you look at the trends across the joint registries, not much has changed in the last quite a few years. But currently, the literature is replete with more and more reports which are coming in favor or sort of more interest in various centers towards cementless knee replacements. However, these interests are not significant enough to sort of create a change in our usages. The salient features of cementless knee replacements are the bone resection have to be performed absolutely accurately, so that these press fit components have to be received very well. They do offer the advantage of a shorter operative time. The newer generation processes have got increased lug holes or increased sort of fixation surfaces and bearing surfaces, which improve the rotational sort of stability of the base plates of the components, which provide a greater stability and more predictable osseointegration. Addition of hydroxyapatite also has changed the sort of the integration properties, and it has reduced the micromotions and therefore sort of slightly improved the results. The patella, however, continues to be a problem. And previous generation also, patella was a problem. The cementless fixation rarely has succeeded, and it was rarely used, but the reason for that was particular metal back components basically led to an early loosening and rapid wear. And therefore, these cementless patellae were not the ones which were very popular. Overall, if I have to just summarize in one slide, what is the difference? So there's not a gross difference between the results of cemented versus uncemented in the earlier period, especially in the femoral components. They produce equally good results. The problem used to happen on the patella and the tibial side. So if you look at the survivorship in vitro studies, the rotating platforms, which DePuy and Attune are pushing now, they seem to have a much better tribologic performance with related to wear. This is in vitro studies and biomechanical studies, and they have sort of extrapolated that this survival of the implant and reduction of the stresses may be in our favor, and this may be sort of what we are looking for. If you look at the hybrid fixation, there are numerous reports in which the survivorship is about 95 to 91% at about 10 years in good numbers of knee replacements in very well constructed randomized trials. Continuing with the survivorship and the revision rate, so there are numerous reports again with the hybrid fixation techniques where they have used different knee systems, and again the success rates hovers between 92 to 95% at about 10 years. It drops down slightly at about 15 years. But overall satisfaction of the patients is good in 91% of the cases. So to cement or not to cement. So general functional outcome, the consensus is that the cemented implants tend to do better because the revision rates are much lesser in the cemented total knee arthroplasties. But non-cemented fixation, if you take the patellofemoral component out of the equation, then the non-cemented arthroplasties also perform equally well. So porous surface with hydroxyapatite coating is the current flavor of the season, and it leads to lesser aseptic loosening. To conclude, the development of new biomaterials basically seems to be very promising. It has got a high conductive properties. The biological fixation is now becoming very attractive option, especially with the advent and our change in understanding of alignment philosophies, newer equipment we have, like the robotic systems that we have seen. And cementless patellae still continue to be a source of concern. Taking this analogy of a little bit further and taking these developments a little bit further, there are people who are now invested in these smart implants. So what are these smart implants we would have looked at? So just imagine this. I mean, this could be a situation out of any movie when we are talking into 2023 that, we received an electronic note. It is sent not by the patient, but by the patient's implant, that there is some change in the characteristic of the fluid around a particular implant. It has sensed that it will send it via a Bluetooth receiver or a transducer to our hospital. The hospital will act on it, ask for the system to deliver some antibiotics or remedial measures. So this all seems like a fantasy or seems like a fancy, but this actually is being done by a lot of people. There are a lot of startups which are there. Orthopedic journals are not full of these articles, but the biomechanical journals, the engineering journals are full of these technologies which are now starting to get incorporated in orthopedics as well. So we have pacemakers, we have remote ECG sensors, and we have different detectors in different parts of the body. But orthopedics is now slowly warming up to that. So the question is, if an implant could talk to us, what would we like to hear from the implant to treat our patient more efficiently? So the applications in the orthopedics it could help us detect loose implants. We would want to know what the force measurements in the knee replacements are. We see our balance is very good, our ranges are very good, but whether the patient is using that to improve his gait, stair climbing ability, the cadence, number of steps he takes, the velocity with which he walks, the confidence with which he walks. In cases of fracture, to assess the bone healing, whether there is a non-healing that is brewing, whether there is increased mobility at the fracture site. If you want to correct orthopedic structural deformities, these nails are there. The magic rods or the magic nails which are there, they are working on the same principles. We can understand the forces in places like the shoulder joint replacements. And these data would also help us arrive at what went wrong and to assess and predict if this joint is going to fail. These smart implants have been used in spine surgery on a experimental basis to monitor the spinal fusion and the movement across the spine. So there could be 4 waves in which these smart orthopedic implants could be used. Currently, we are on the wave 1. So we've got smart tools in our operating theaters. I mean, we personally have not used them. Some of the robotics, they incorporate that, but you have those sensor trials where there are these pressure sensors, and these pressure sensors will give a feedback to the surgeon. These smart tools would be intuitive, and they would give the surgeon feedback as to what he should be doing next. There could be a second wave or smart diagnostic on demands. For example, if an implant could talk to us, this could be accessed by the doctor. If there is a transducer in the patient's tibia, like for example, that is being done by Zimmer and the Persona knee, they have a extension. This extension is implanted into the patient, and this talks to the cell phone or a smartphone via Bluetooth or via a transducer. It tells us information about what the patient has been doing in all those interim follow-ups. The third wave, where we are not there yet, but this is all in a research or this is in an experimental stage, is that if there is a smart diagnosis by exception, that means the implant or the sensor over there could continuously be monitoring the environment around the bone implant interface or the biology or the environment around the bone. And if there is some change, let's say, for example, there is change in the pH of the fluid around the implant, or there's a change in the temperature, or there's a change in the vibration which is being picked up by the implant, then this could be sent to the surgeon. Now, all this data could be gotten by the surgeon. It could be compared to a known standard, and then the surgeon could act on it. So we are talking in quite a few years in advance. And the last thing is treatment by exception. when the implant could be sort of programmed to act on it. Let's say it picks up a change in the pH, which would mean that there is an infection which is brewing over there, and immediately there could be a mechanism that would release sort of the antibiotic which is stored in the implant at that particular moment in time, or we could have a drug delivery system over there which could prevent any complication. So to give you an example, so basically ortho sensors are the ones which basically we use for tensioning. The spine implant, which I mentioned, is called the IntelliRod spine. It has implanted with it is implanted with a wireless RFID sensor, which monitors spinal rod stresses and strains around this thing. The smart diagnostic, which I mentioned, is currently being launched by Zimmer, but all the other companies, including Smith & Nephew, Depew, Biomed, they're all working on the similar lines. And this currently gives information regarding implant positioning, the load bearing data, range of movement, and even the gait analysis. But what we would like to know in the future is basically if there is a bone ingrowth, if there is a particle around a particular implant that we could see from the pH, or it can have a link to the osteolysis. The temperature, there are temperature sensors which are in the femoral sort of neck or the femoral, stem, which are implanted, and they could be sort of measured. The pH, lactate, glucose level. So all these things could be seen. And these are the technologies that are existent. They are being married to the implants, and this will probably result in spine implants or the implants that we are using. So these all studies are there from biomechanical journals where they have got these models. They are being used in animal models, and there are very, very few reports where they have used in particular patients. The essential principles, I'll just give you a gist of it. It basically works on either vibrometry. So they have got a particular behavior of an implant. Let's say you have a hip replacement. And this vibrometric basically measures the resonance and frequency around the implant. So if that is, extrapolated, gotten into your computer system, and you see that if there is a particular acoustic behavior, then this is a well-fixed implant. But if the acoustic behavior changes, then it could mean that there's a osteolysis or there is a loosening on the implant. Secondly, you have those blood flow ultrasound probes. So you can see that if the blood flow or the fluid is flowing in a particular manner around the implant, it tells you that, this is a well-functioning joint. But if there are eddies or there are different currents which you can pick up, then it is something wrong with that. These oscillators, basically, they align to a magnetic field. So if you have a magnetic field, you align these oscillators to a particular frequency or to a particular field, then this could be again used to see if it behaves the way it was behaving when it was implanted or the behavior has changed. For research purposes, there are these force measurement tools which are being put into the tibial polyethylene, and these use basically real-time force measurements. They can be put in individual compartments. And they work on a wireless piezo-resistive strain sensors. So these are all complex technical terms. I sort of understood it briefly while I was reading through it. But what it tells us is basically it will tell you exactly where the strain is, what the normal strain pattern should be, and what the strain pattern the patient particular has. So there are numerous studies which are showing these incorporation of these implants in different sites. To give you a perspective, how big are these implants? So this is one particular company, and I actually had to go to LinkedIn to find the size of this implant. So this is the finger, and that's the actual size of the sensor that can be implanted and that can be talking outside the patient's body. So these are tremendous developments which we see. The micro batteries, the other question that came to my mind, that these joints are going to stay in for like 10 or 20, 15 or 20 years. And are these batteries going to last that long? But then apparently these batteries are a different kind of batteries. They have a potential to charge themselves as the patients are walking with the changes in the pH, with the changes in the current of the fluid which are there. And therefore they look very promising. These are the gauges which measure the temperature. These are completely sealed within the tibial sort of, the stem. So these are actually smart implants. The challenges that the community foresees is whether these implants could be biocompatible, whether we could actually use them. That is one. The wireless interface, and basically, lastly, how to power these implants to last for a patient's lifetime. So all in all, the smart implants are here, and they will help us. It is up to us to make sense of what this data is going to give us. Right? I think there was a recent editorial by Dr. Graichen who said that this robotics, what it is doing currently, it is just giving us a lot of data. It is churning out a huge amount of data, and it depends on us and the intelligence and the sort of machine learning what to do with this particular data. And what we do with this data is only going to determine what the next generation of robots is going to do. Thank you.